So I am going to be presenting perspectives, not necessarily research study and that looks at results, but I'm going to talk about what we're seeing as we implement projects around the world. So I'm just going to go through a quick introduction, understanding the exposome in this particular space, child health stats in sub-Saharan Africa, an illustrative example of malaria in Nigeria, current efforts, and some recommendations. So a little bit about me. My name is Aday, an apple a day, a vitamin a day, you'll never forget. I am the Vice President for Global Health Program Delivery, which simply means project implementation. I oversee all of our project implementation. And MSH has a presence in about 42 countries right now. And our work, as Pat said, is really in strengthening health systems. So we go in and look at the 6 pillars or the building blocks of health system strengthening, and we address each of those depending on the need and depending on the context. And our work is, we're at 51 years old now. We have been doing this working shoulder to shoulder with host country governments, providing capacity strengthening technical assistance, and allowing the importance of locally led solutions to thrive. And so we are funded mostly by USAID, and we are really moving the needle in sustainable healthcare delivery. For me personally, I've been in the US government. I worked for the CDC in Nigeria, overseeing the clinical services and program management of the PEPFAR program, which is our global HIV program in Nigeria. And then I did about 8 years with USAID as a regional HIV advisor, and then moved on to HRSA as the director of the Office of Global Health, where I met Pat. They were one of our grantees. And now in the last 2 years, I've been at MSH as a VP. So just a little bit about me. So we have a persistent challenge, which is why we continue to do health system strengthening in sub-Saharan Africa. All kinds of issues. I think we are all aware. There's poverty, there's there's weak governance, I should say, and weak infrastructures that lead to poor health outcomes. But we're seeing some improvements as we move forward and as we've been tackling these challenges. And while infectious diseases remain a concern, we still have not paid attention to the negative environmental exposures that are impacting child health survival. And just listening to all of the folks here today and realizing that it's not only in sub-Saharan Africa that we haven't really addressed and tackled what we're seeing in terms of negative environmental exposures and how they fit into the exposome. That whole thing of it starts preconception and continues to death, and maybe and all of that in between. I have been sitting today reflecting on, okay, how can I be more intentional? How do I take this back and make this make sense for the work that we do as well? So today I'm just going to touch on some environmental exposures in the exposome and their diverse effects on child health in sub-Saharan Africa. So many have mentioned today, everyone before me has mentioned this thing about the totality or the aggregate of environmental exposures, beginning with, as Matt said, pre-conception and all the way to death. And what we see in sub-Saharan Africa, and I think even here, I haven't spent much time in the domestic space, but as I've listened today, I've been thinking, especially threatening in the first 1,000 days of life. And so what do we do? How do we engage intentionally and deliberately to minimize the impacts? Dr. Miller said the exposome is the environmental equivalent of the genome. And while that is static, the exposome is dynamic and changes over time and space. So understanding the exposome is important for developing tailored and robust public health interventions. So we don't focus on just the disease and treating it and case managing it, but what are the causes that we can impact to reduce or mitigate the risks to health. The research, this type of research in sub-Saharan Africa is relatively new, but is growing as we talk about climate change and the impacts on health. So just a few stats in Africa. And by the way, my presentation is going to be rescuing time for us. Okay, so we're going to finish my presentation fairly quickly. So we look at some mortality data from the WHO, the World Health Organization. Almost 6 million children under 5 died in 2015. More than 50% of those deaths were preventable. And leading causes were preterm birth complications, birth asphyxia, diarrhea, malaria. And one of the findings from one of the statements the WHO made was that more than 14 times, that children in sub-Saharan Africa are more than 14 times more likely to die than children in developed regions. USAID put something out 2 years later that says that number is more than 16 times. Main underlying factor is malnutrition. And when we look at what are some of the common exposures, we're seeing a lot of flooding now. There are countries in Africa that never experienced the types of flooding that we're seeing today. We're seeing earthquakes, we're seeing all kinds of things. But the flooding that we're seeing in multiple countries, I think of DRC right now, in Brazzaville. Right now, whole communities are being swept away, 1.8 million people displaced in the last few months. So when we look at flooding and the impacts of climate change and deforestation, flooding sweeps away the crops, and a lot of people are subsistent farmers, which leads to malnutrition, stunting. And then we also have flooding contributing to malaria, because the mosquitoes that transmit malaria grow and proliferate in stagnant pools of water. So when the sewage systems and the sewer systems are not prepared for the amount of rainfall, then we have water sitting for a long time, and we have those mosquitoes proliferating and transmitting the malaria to more people. So there's also soil and water pollution that lead to diarrhea, malnutrition and stunting, toxic air, premature births, asthma, cancer, chemical hazards like lead poisoning, cancer as well. These are just illustrative. And then I just wanted to talk about Nigeria as a case, not a study per se, but just as a case, because we're seeing some movements there as well that are impacting health outcomes for children. I have some stats here that I won't go through. The main things that I'll notice, the main things I'll mention are that the population in Nigeria is approaching 220 million people. So it is the most populated country in in Africa, the continent, right this minute. And it has a tropical climate, 2 seasons, rainy and dry, so you can imagine that the cycles for malaria are matching up with the seasons. So we get more malaria in the rainy seasons. Average annual temperature is 21 to 35 degrees Celsius. It's fairly warm, and it's LMIC. Something to note here is health insurance coverage of 3%. 3%. Country of 220 million people, almost 3%. However, an Health Insurance Act has just been passed in 2022, and we're hoping to see some forward movement in this space. Again, for a population of 220 million people, there are 166 tertiary hospitals. And so the best care, or the most advanced care, is limited to 166 hospitals. So some health impacts, environmental health impacts on kids in Nigeria. First of all, I want to just say that the country is ranked second of 163 countries in terms of risk that climate change poses to children, second. And also ranked second of 33 countries classified as extremely high risk. So therefore, there is a particular vulnerability of kids to air pollution, coastal flooding, water scarcity, water sanitation and hygiene that lead back to some of the things I mentioned earlier. We're also seeing extreme weather events. As I mentioned, there are now earthquakes in places where we've never had them. There's flooding that is unpredictable. There's floods and droughts in places that we didn't expect to ever see this, which is impacting the health outcomes we mentioned before. And we're also seeing a spread of vector-borne diseases like malaria and dengue, malaria accounting for 70,000 deaths for under 5 children every year. So just want to hone in on this in terms of malaria among children under 5. The country bears the largest burden of malaria in sub-Saharan Africa. More than 70% of Nigerians live in endemic areas. And again, all due to changes in the climate that the government is not yet ready to handle. One thing I'll note here is the length of transmission has been increasing year after year in malaria endemic parts of Africa, Nigeria included. So if it used to be 4 months, now we're saying 5 months, 6 months, which means more transmission, which means more disease, which means more death. And the children under 5 are more likely, in these areas, are more likely to die of malaria infection. So what are some of the current efforts? Organizations like MSH are working closely with the government through funding from various partners to increase attention and mobilize domestic resources to track environmental changes, because you've got to diagnose before you treat. What's happening? How do we fix it? And strengthen the capacity of various actors in the health sector to truly advocate for more resources, advocate for the right thing to be done, to monitor what these exposures are and use multidisciplinary approaches to tackle. Key to this is involving local communities. Nigeria is very diverse in terms of its ethnic groupings and cultural groupings. And so you've got to figure out which messages are going to resonate with which groups and allow the local actors to really drive the process. So it's not a one-size-fits-all. It's not what worked in Uganda is going to work here, but how do we really get the voices of local experts to drive how we program. We are now in the space of mitigating the impact. We're not yet preventing, we're mitigating the impact with sanitation campaigns, seasonal malaria chemoprevention campaigns, and insecticide-treated net campaigns. But we've got to get to the space where we're looking at the exposures and how we prevent. And I just had some recommendations here for those who are engaged in this space on the international stage. As I mentioned, put local communities at the center. It's key for sustainability. Otherwise, the project will start and end. And once it ends, we're right back to square one. But when there's local buy-in and leadership, it stays much longer. We want to scale effective local solutions once we identify them and scale them. We want to provide flexible financing directly to local communities. This is a call to our funders. And support an enabling environment for sustained progress on local adaptation. Climate change is real, it's happening, and we need to make sure that health is part of that dialogue. Stay flexible, open to innovative ideas. And I wanted to say that global cooperation can amplify local efforts. As we are all discussing this today, there's so much to learn from the US domestic experience and so much to learn from the international experience. And how do we engage in that bi-directional exchange so we're not reinventing the wheel all the time? So my call to action, more research and practice are needed in this space. We need to catalyze agency to local communities through funding, partnership, and knowledge exchanges, not parachuting in and telling people how to do business in their space, but really to listen and partner. And that public health practitioners can truly advocate for the inclusion of environmental factors in program design. It's largely absent right now, but I think the more we think about it and the more deliberate we are, we can actually move the needle. Thank you very much. That's all I got.